Welcome everybody to the Wellman's Podcast. Brian and I are really excited today because I get to talk with my best friend, my love, my wife, Jillian, and we're going to be talking about Sibo, which I think stands for small intestinal bacterial overgrowth. And anyway, I'm really excited to talk about that. Brian and I are. Welcome, Jillian, and thanks for being with us again, Brian. I'm through your exams. I can't wait to talk about what you've been studying too on upcoming podcasts. So welcome, Jillian.
Good morning. Thank you guys so much for having me. I'm happy to be back.
So I guess the main question, Jillian, did I get that right? The acronym? What does that stand for?
Small intestine bacterial overgrowth. You got it. You got it.
And I see a lot of that out on the internet sphere, and to me it almost seems like a fad. Why is it being talked about so much now?
Yeah, so a couple things. First, well, truly, we really have only known about Sibo for, just a few decades. It was discovered in the 90s, and then in the last 10 years or so, research and clinical detection has really ramped up. And as you know, of course, the cutting edge of things is anywhere from 10, 20, 30 years ahead of what is practiced clinically in the trenches with folks one-on-one. So it's not like it's this new fad, but very much methylation and histamine intolerance are things that we've only recently begun to discuss in earnest. Sibo's also one of those categories as well.
Okay. So how do you know if you have Sibo?
Yeah, that's a great question. So what I would say to your listeners is if someone has chronic digestive distress and or a digestive diagnosis, okay, and they're being treated and they're doing everything right, but they're still having symptoms, you want to consider small intestine bacterial overgrowth because there are a couple unique things about Sibo in particular, and we'll talk about all of that today. If you want me to just launch into that, I certainly can.
Well, I guess the next question would be, okay, so you have these persistent chronic digestive things. Now you're starting to think about Sibo, but how can you objectively tell if you actually have this?
All right. So let's back up before we get into testing. So what Sibo is, it is a larger than normal number of bacteria that live in the small intestine. So we used to think that our small intestine had no bacteria at all. It was completely sterile. That's actually not true. We do have some, all right, just a little bit. However, if those numbers exceed a certain threshold, these bacteria are doing their bacterial thing, right? They're fermenting, they're metabolizing, and we are exposed then to their metabolic byproducts, the gases that they're making, and the compounds of their cell walls as they are dying. And this produces a myriad of symptoms, right? Gas, bloating, indigestion, stomach pain, spasm, even things like fatigue and muscle and joint pain and mood and skin changes. So these symptoms are extremely general, right? They're generalized, they're common, they're virtually indistinguishable from something like IBS, irritable bowel syndrome, or another functional GI disorder. And because of those two reasons, because the symptoms are so generalized, and because Sibo not often, I would say 99% of the time, Sibo is found with another digestive disorder. It's found with IBS. Up to 85% of cases of IBS also have Sibo present. It's found in 20% of folks with celiac disease. If you have gallbladder trouble or fatty liver, you have increased risk for Sibo. If you have gastroparesis, even if you're a woman, you have endometriosis, there's many conditions that increase risk for Sibo and that Sibo rides along with. So the generality of the symptoms plus the fact that Sibo jumps a ride with other conditions essentially cloaks Sibo. So clinicians aren't thinking about that when they're coming, when they're having a visit with a client, they're thinking, okay, they're either not being compliant with the treatment plan or all of these symptoms are attributed to the original diagnosis, right? So it's like SIBO can hide in this way, and it often does.
Are you typically going to experience these symptoms 24/7, or do they come and go with SIBO?
You're going to experience like the gas, the bloating pretty quickly after eating within 30 minutes, but the other stuff can be experienced 24/7. So there can be some waxing and waning. There can be consistency of symptoms throughout the day, but you are going to notice that those symptoms are going to be particularly strong right after eating or within 30 minutes of eating.
Okay.
So they rise with other conditions because those other conditions compromise the gut to some extent that allows for the bacterial overgrowth?
Yeah, that's another great question and a good segue to a main point that I want to make about SIBO. SIBO hardly ever arises externally by itself, like singly in a body, right? SIBO rises usually because these other conditions have created circumstances in the body for which it can arise. And there's a couple things with that. The first and most important is that the motility of the small intestine is slowed. Okay, so appropriate movement of the small intestine is governed by something called the migrating motor complex, the MMC. This is a division of our second brain, right? Our second brain lives in our gut, it resides in our gut, and it is managing and monitoring all aspects of digestion, including motility and movement of the gut, right? And how frequently we're having bowel movements, all of these types of things. So with SIBO, that MMC, that migrating motor complex, becomes compromised. It slows down. In a healthy MMC, what happens is that there are these rhythmical pulsatile waves that go through the small intestine every 60 to 90 minutes. And what these waves are doing is they are propelling food like down towards the large intestine. When those waves don't happen and the small intestine is slowed, the food is just essentially sitting there. So the first piece is a slow small intestine. The second piece is some breach of defense, right? So our body uses stomach acid, enzymes, and bile to prevent small intestine bacterial overgrowth. All of those things are not only crucial for breaking down our macronutrients, they're also very powerful antimicrobials that help kill any bacteria looking to establish itself and colonize a small intestine. So if we, I don't know, say we're on acid blockers and we've got IBS, we are creating a perfect storm for SIBO to manifest. So our defenses have to be breached, and that migrating motor complex has to be compromised in order for SIBO to manifest. So you're not going to get SIBO from, a healthy, normal person is not going to get SIBO from drinking kombucha or taking probiotics or eating sauerkraut or things like that. I see some like whisperings of that like out on the internet, like, oh, I don't want to give myself SIBO by drinking kombucha. It's very difficult to do that. Like, that's not going to happen.
Yeah, that was one of the things I saw in my quick Google search of just about SIBO was that you could basically drink too many health products and gain SIBO.
Yeah, it's really, really hard. I mean, if you were compromised, I guess you could, but it's really, really hard to do that.
Yeah, it's much easier if you can be compromised from taking acid blockers, or you alluded to maybe having your gallbladder removed.
Yeah, so even not even like gallbladder surgery, but even like gallstones and sludgy bile, anything that's going to prevent like nice thin bile from being able to do its job. Also, I think didn't we all do didn't we do a podcast on gallbladder stuff?
Yes.
So remember, so let's see if your listeners remember this. So bile is absorbed 95% by the small intestine. So by the end of the small intestine, 95% of the bile has been recovered. So if your bile is all bound up in stones and sludge and you don't have like thin, healthy bile, not only are you like maldigesting fats and such, you're also losing out on that antimicrobial property of bile.
What about if you're not chewing your food completely, or you eat too fast? Would that affect it? I mean, I guess that would compromise your gut indirectly over time, which is obviously.
That's probably an indirect way to get it, but certainly like if you have IBS or you have one of these or like, IBD or one of these digestive diagnoses, you definitely want to be like eating slowly, chewing your food until it's soft, those types of things for sure.
Okay.
But if you're eating fast and not chewing your food, but your small intestine is moving appropriately, chances are you're going to be pretty safe. Like you might get some gas and bloating, but it won't be because of SIBO. It'll be because like your stomach is just like overwhelmed by macronutrients that it has to break down.
Would constipation do it, or chronic diarrhea?
So either one of those are characteristic of, colitis, inflammatory bowel disease, and irritable bowel syndrome. So those all speak to like compromises in the second brain. So yes, these conditions definitely can predispose one also towards SIBO for sure.
So when we talk about overgrowth, right, are we talking about specific bacteria, or are we talking about just normal gut flora?
In terms of SIBO, it's a number cutoff. So this could be translocated flora from the large intestine, from the colon, or this can be other types of flora. There have been studies, aspiration where they like basically are sucking out contents of the small intestine, analyzing them, that some have shown that it is translocated colonic bacteria, and then others show that it arises from elsewhere. So we're getting it in through other means.
Okay, so it's not the normal flora then. It's not exactly an overgrowth of flora without invasion of other bacteria from other places.
Well, no, sometimes it is. So sometimes it is and sometimes it isn't.
Okay.
Sometimes it is and sometimes
that makes me think that taking antibiotics may bring it on or not.
Yes. So this is interesting because taking antibiotics can transiently relieve the symptoms, usually transiently because there's a very specific antibiotic for SIBO. And then also antibiotics predispose. So it's like they do two things. It's like they might relieve symptoms for a few days or a few weeks, but they also predispose for bacterial overgrowth. So the medications that predispose for SIBO are acid blockers, antibiotics, birth control pills. Those are the big ones. Oh, and opioids, of course, because opioids slow everything down.
Wow. As a clinician and not having your expertise on gut health, when I see people with digestive issues, a lot of times, and I know a lot of naturopathic physicians and medical doctors are doing this, you see these like the spectrum of symptoms of gassiness, bloating, somebody just not feeling comfortable after every time they eat. And a lot of times what I will do, and I know a lot of other clinicians will do without really going into further detail or testing, is just recommend digestive enzymes or a probiotic. Mm-hmm. Is that appropriate way to go about it, or could that make things worse?
No, I don't think it's going to necessarily make things worse. What I would say is that if you do all of like your normal, good, basic interventions for digestive distress, you clean up the diet, you throw some enzymes in there, and it's not helpful, that is when I would consider SIBO.
Okay.
Right. It's kind of like SIBO should be considered when you're trying different things and nothing's really helping, or it's helping a little bit, but not really. That's when you want to think about SIBO. If you're able to, identify that someone has, I don't know, a gluten sensitivity and they just need some enzymes for a few months, like then that's a different thing than small intestine bacterial overgrowth.
So if I'm suspecting SIBO, then what's the next step then?
Mm-hmm. So then what we would do is we would do a breath test. So SIBO is most commonly diagnosed via a breath test using either glucose or lactulose as a testing medium. So these tests are either done at home or like in the doctor's office. And essentially what happens is that they're usually done in the morning because you want to be fasting. And basically the test is you're blowing your breath into a series of little tubes, like a little breathalyzer. So you get your baseline breath and then you drink the solution. And then at timed intervals, you are blowing in the tubes and you package those all up, either send them in or the technician collects them. And then the lab is looking for a rise in either or both hydrogen and methane. So if there is a increase of 20 or greater parts per million of hydrogen, that's diagnostic. If there is a rise of 10 parts per million or more in methane, that's also diagnostic. And you don't need both.
Okay.
Okay.
So let's say you have your diagnosis now. You confirmed it through these tests.
Yep.
What's the next step from a clinician's point of view?
So there's a lot of considerations here, especially from an integrative perspective or from like a non-conventional perspective. From the conventional perspective, they're going to recommend the antibiotic rifaximin. And I actually like rifaximin as an antibiotic, and I will tell you guys why. One, it's not absorbable through the GI wall, and it does not enter the body. So it doesn't have the systemic effects that other antibiotics have. Like, it's not going to like rupture your tendons. The other thing is that is bile soluble, right? So it's active really like in the presence of bile. And so once it leaves your small intestine, it's really not going to have activity anymore, right? So really its action is confined to the small intestine. Okay. Lastly, unlike other antibiotics, it doesn't negatively shift the landscape of your healthy, beneficial microbiome. Okay. So it's not like going to compromise your microbiome like others do. But rifaximin, although it is highly effective, relapse rates can happen between 30 and 40%. And so we have to look at what is going on here. And that's why I like to use an integrative approach, which includes other antimicrobial herbs and compounds, because an antibiotic has one mechanism of action, but herbs often have multiple mechanisms of action. So we can have a more comprehensive battle against the colony. Another thing to consider is that in about a third of SIBO cases, we can also have overlap with yeast or fungus. So an antibiotic is not going to be effective against these organisms, right? And so these would be like what doctors would say like are hard to treat cases. If we are treating candida, or, you know, we call it SIFO, right? Small intestine fungal overgrowth. If you're treating SIFO with antibiotics, you're not going to get anywhere. So we use herbal compounds as well. But then there are two other very strong considerations that we have to look at. The first is the fact that because these bacteria are in an inhospitable environment, the small intestine, they are very prone to forming biofilms. So a biofilm is basically like a little fortress that the colony makes using polymers that the bacteria make themselves and also utilizing materials from your own body. So they create a little fortress to protect themselves against antimicrobial therapy. So we have to use a biofilm buster along with our antimicrobials, whether they're conventional or natural or both. You know, in my school and in my program, I recommend both. I recommend rifaximin and I recommend natural antimicrobials. And we take that with a biofilm buster. I really like Interphase Plus by Claire Labs. It contains specific enzymes and chelating agents that help bust up the polymers and the metals and all of these things. And then the other consideration for SIBO treatment is the use of a prokinetic agent. And these are compounds that help to reestablish appropriate motility of the small intestine, right? So you don't just want to like kill off the infection, you also want to get the small intestine moving at the right speed again, right? That Goldilocks zone, not too fast and not too slow, because that MMC slowing down is one of the major roots of SIBO itself. Okay. So when we're thinking about treatment, it's not just like, oh, I'm going to go get rifaximin from my GI doc and like never think about it again. You know, we do a natural killing protocol. We use biofilm busters. We use prokinetic agents. And then there's a whole other piece that we can do with our diet and nutrition to help manage symptoms as well.
Can you just go into biofilm buster, that you mentioned enzymes and chelating agents? What are the meds or natural
Interphase
drugs?
Plus. It's Interphase
Interphase
Plus by
Okay,
Claire Labs is the one that I use the most. I know that Dr. Paul Anderson, he's a naturopathic physician. He has his own like patented formula for a biofilm buster, or I think he has two of them actually, one for yeast and one for bacteria. But I tend to use Interphase Plus by Claire Labs because it's like old trusty.
Okay.
Old faith.
And that's just a combination of natural, I guess, chelating agents, that it breaks up the mortar or whatever around that fortress of that biofilm, and then the enzymes chew up the wall, so to speak.
Yep.
Okay. And then what was the other one that you said? So you have the biofilm buster, and then what's the other?
The prokinetic agent.
What would that be?
So there's natural versions of that, and then there are pharmaceutical. So pharmaceutical prokinetics are things like low dose erythromycin, low dose naltrexone. Natural ones, a great prokinetic is just ginger tea, ginger caps, and then digestive bitters, like something like gentian root.
Yeah, right.
And then there is a formula, I believe it's German, called Iberogast. And that is one that I use a lot because it's readily available. It's available in a lot of drugstores. It's available like on the internet. It's very inexpensive, and it also really works really, really well. And Iberogast has actually been studied against some of the pharmaceutical prokinetic agents and has been shown to really hold its own. So I like that quite a bit.
Okay. If you have Sibo, right, you have this overgrowth, does that also mean that you have the biofilm?
I would assume yes. I would assume yes, because of the inhospitable environment that the small intestine presents to the bacteria. They have to find a survival mechanism. And most particularly, I suspect biofilms, if people come in and they've already been diagnosed with SIBO, but they're not getting anywhere with their symptoms on rifaximin alone, or they're having multiple relapses. We can blame failure of treatment on either biofilms and or the presence of organisms that are non-bacterial. And
is there a test for biofilm?
There actually is. I don't know the lab, but I do know that some clinicians are checking for biofilms. But because there's no real downside to using Interphase Plus, it's almost like not worth the expense to see if a biofilm is present or not.
So if you have SIBO, it's really, I'm getting from you that it's best to talk to your naturopathic physician, and like us, if you're in an unlicensed state, to definitely have that naturopathic physician working with a conventional doc to treat it.
Mm-hmm. Yeah, or sign up for my SIBO school and you get kind of like the blueprint of how this stuff looks.
So to tell us about that then. I mean, how do you sign up for that, and where would people find that?
It's on my website, JillianTeta.com, and we can include the links. But it's basically hosted via my online classroom, and it's just multiple lessons and PDFs and like downloadables and stuff, and a whole, flow of a integrative approach to SIBO management.
You have that other website, Fix Your Digestion. Is it there, or is that attached to your website under your name?
No, my website is just JillianTeta.com. Fix Your Digestion became Jillian Teta about 18 months ago, honey.
Hey, I'm out of the loop.
Okay.
All right.
Yeah, Fix Your Digestion is no more.
Well, so, hey, if I don't know that, if I wasn't aware of that, I'm sure there's plenty of people out there that were not aware of that.
Well, they just go to my normal website, which is Jillian Teta.
Thanks for keeping me on track, honey.
Okay.
Is there anything else we should talk about with SIBO, or that we should know?
Well, sure. So the nutritional approach for SIBO is comparable to one you would do for something like IBS or IBD, which is a low residue, low FODMAP approach. So FODMAP, for the folks that don't know, FODMAPs, it's an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So this is just a fancy way to say certain types of carbohydrates and fibers that are highly fermentable, aka gas producing, to a dysbiotic, a dysbiotic microbiome. And Sibo, of course, would be an example of that. And so FODMAPs are present in a huge variety of healthy vegetables, fruits, grains, dairy products. They're everywhere, broccoli, apples, onions, melon, apricots, soft cheeses, these types of things. So by reducing the volume of fermentable fibers that you're putting into your body, you're going to greatly reduce symptoms quickly.
Okay. But on one hand, it seems like once you have a healthy gut, you do want those FODMAPs there, right?
Oh, sure. So a low FODMAP diet is going to be the most appropriate for people that have like an imbalanced or a dysbiotic flora, because they're going to be more prone to these highly fermentable foods. And then of course, like there's always going to be some people that like, I don't know, they just don't do well eating cabbage and they're fine, but like it's just too gassy for them.
Okay. These are like prebiotics, right? These are prebiotics that, yeah.
Yep.
Okay, certain
Yep.
types. The diet sounds restrictive. It sounds like if you're mostly vegetarian, you're going to have a hard time eating that.
No, because there's plenty of low FODMAP vegetables and fruits out there. You just have to make essentially just a lateral shift, so instead of eating, I don't know, broccoli and Brussels sprouts, you're going to be eating zucchini and summer squash, those types of things.
Okay.
So is this something someone's going to have to manage throughout their life, or can they eventually, I don't know, be SIBO free?
Yeah, that's a great question. So even with just rifaximin alone, treatment is 60 to 70% successful. So using an integrative approach, you really can drive that up, especially if you go back and do other things like, healing the lining of the gut, after an infection and these types of things. So I can't even tell you how many folks who have successfully completed SIBO treatment and have been able to reintroduce many of these foods back in and have been just fine.
Okay.
But for some folks, yeah, it's like this chronic thing. And I think it's because all of these pieces are not being pulled together.
Right. That makes sense.
Yeah.
What's the percentage of people that may have this in the population?
So US, like just people, is about 16%. Not all of those people are symptomatic. So SIBO also can be one of those things, kind of like, if we did an MRI on all like 35-year-olds, a certain percentage of them are going to have, herniated discs or something like that. But not all of the people with herniated discs are going to be symptomatic. So it's like that.
If you don't treat it, is it life-threatening?
It's not life-threatening, but over time, it can create nutritional deficiencies and even immune overstimulation in a dysfunctional way. So if it's found, and especially if folks are symptomatic, I think it should be treated. Absolutely.
Because you may be more prone to all other types of chronic.
Well, yeah, you're going to get long-standing malnutrition, potentially like osteopenia and anemia and weight loss and fat malabsorption and all of those things, especially if there's multiple diagnoses on board. People just get, eaten up.
Right, and your small intestine is where most of your absorption of nutrients happens anyway, right? So if that's compromised, you're going to have a big problem over time.
Yes.
So is there any correlation with autoimmune disease and SIBO?
Not that I'm explicitly aware of, but you certainly could imagine that there can be.
Yeah. Okay. What else? Anything else we should talk about with that?
With SIBO, well, I think like to summarize, like the most important things are the symptoms are extremely general. Okay. So it's going to look like so many other digestive disorders. It also is found with all of those digestive disorders. So it can be cloaked, right?
Okay.
So again, folks who have been struggling for a little while, and they already have a diagnosis and they're doing all these things and they're not really getting any better, should definitely be thinking about SIBO. SIBO is diagnosed via a breath test. It cannot be diagnosed via stool testing or urine testing or oat testing or these types of things. While these tests can detect dysbiosis, they can't isolate it to the small or large intestine. So by using the breath, we're examining the upper GI tract. So that's really what's diagnostic. There's another test for SIBO. It's intestinal aspiration, where they run a tube down your throat and they suck out the contents of your small intestine. But the only issue with that, and then they do bacterial counts, but then the only issue with that is they are only aspirating essentially the duodenum, like the first part of the small intestine. So it's going to completely miss overgrowth that might be further down the small intestine or closer to the large intestine, where a breath test is going to capture that. Particularly lactulose breath test is going to detect SIBO in a greater range of the small intestine. Glucose is broken down in the proximal intestine, like the part of the small intestine that's closer to the stomach.
Okay.
Lactulose, so it's going to capture stuff there, where lactulose is broken up further down, closer to large intestine. So it's going to capture greater range. And especially if we're thinking about translocation, you're going to want to examine like the distal or far part of the small intestine as well.
Right.
Okay. And then for treatment, you want your conventional antibiotic, you want your natural antimicrobials that are going to have antibacterial and antifungal action both. You want your biofilm buster, you want your prokinetic.
Okay.
And you're going to remain on that for, I have people on that for anywhere from 8 to 12 weeks.
Wow.
Yeah.
I would think if you had any type of surgery or you had any part of your small intestine removed, you'd be highly prone to this, right?
Yes, that's a great point. So other things that increase risk for SIBO are any type of abdominal surgery or resection, including bypass surgery, and also traumatic brain injury.
Really?
Yes. I read a whole thing about this because traumatic brain injury basically disrupts the second brain and the migrating motor complex.
That's interesting. So you're talking about the intimate interconnection of the brain and the gut brain or the gut.
The second brain, yeah.
Yeah.
The central nervous system and the enteric nervous system. It's like that communication gets like interrupted. So yeah, traumatic brain injury, like concussion, that can really like screw people up.
Bring it on. Wow. Okay.
Yeah.
Brian, anything else we should know about SIBO?
That was great.
Yeah, that was great. Anyway, Jillian, thank you for being on. Can you just remind our listeners where to find you again?
So my website, the listeners and my husband can find me at.
I could find you in the next room. Right?
So my website is jillianteta.com. And there you can find Sibo School. I have a ton of free resources and free programs and free downloadables. My blog is on there. My book is on there. All social media is on there. And then the direct link to Sibo School itself is bit.ly/Sibo School.
Oh, cool.
Awesome. And it is in the show notes. So you can click on it on the device you're listening to right now.
Yeah.
Thanks, Brian.
Jillian, thanks for being on again. Brian and I always love it when you're on, and I especially like looking at you on video.
Tierney, Brian, thank you guys so much. We'll do it soon again.
All right, great.
Thank you.
Good. Bye.
Bye, guys.